Today we are going to learn about history and examination in vertigo. History and examination forms 90% of diagnosis in vertigo, therefore we'll focus on history and examination alone. Vertigo is an illusion of motion when there is no motion. It can be because of peripheral cause, that is because of the autological cause, or it can be because of the central, that is the central vestibular connection, the brainstem and the cerebellum. The equilibrium is maintained by the inputs from the ear, otological organ, the semicircular canals, the ventricle and the saccule, the proprioception joints and the skin, the visual input, and they are centrally coordinated in the brainstem and the cerebellum. When the information received from these different sources, they are not at variance, or there is disturbance in this information, or there is irregular uh, information, then we experience vertigo. The patient will describe giddiness or spinning sensations in various terminologies, so we should be able to differentiate these different terms. Vertigo basically means rotating or spinning sensation of motion when there is no actual motion. So that is vertigo. That's the true vertigo. Now, syncope means there is transient loss of consciousness which is lost to postural muscle tone. So it can be because of anything that reduces oxygen to the brain will lead to syncope. Lightheadedness is impending loss of consciousness or blackouts. For example, in anemic patients, they may experience lightheadedness. Disequilibrium basically means imbalance or sensation of floating while walking. Usually patients with cerebellar disorder, they present with the unsteadiness on walking. Dizzy means, they have the, tendency to falls. So any falls that can be because of the autological cause or because of, for example, Termakin crisis, all this leads, they have the sensation of dizziness. Unsteadiness, feeling like not walking straight or may fall down anytime. So we should understand that these different terms, and patients actually don't understand what these terminology are used for. So we should be able to actually differentiate what they are trying to say. Thus, when the patient complains of giddiness, vertigo, dizziness, unsteadiness, we have to first of all make sure that they have actually a balance disorder or not. If they have a balance disorder, whether it can be central or it is a peripheral cause, then if it's a peripheral cause, what is the possible etiology? So we have to take a thorough history in order to come to a diagnosis. So we should take a history of like duration. What are the aggravating factor? What are the relieving factor? What are, there is any history of trauma, any history of headache, whether it's episodic or not. Uh, how, ask them to describe the first and last episode of vertigo. How frequent are the vertigo? All this will give clue to the diagnosis of vertigo. So the duration of symptoms. Some vertigo classically occur few seconds. For example, BPPV occurs very and comes and disappears within few seconds. Or some some vertigo, they last for seconds to minutes. It can be a BPPV or panic disorder, or some cardiac arrhythmias leading to giddiness. Minutes to hours. It can be because of the Meniere's disease or panic disorders, TIAs. Hours to days, it can be because of Meniere's disease or migraine-associated vertigo or vestibular neuronitis. It can be, giddiness can last from days to weeks in migraine or in stroke and drug-related. or sometimes it can be chronic, lasting months to years, especially in stroke, if there is ototoxicity, or perceptual, chronic perceptual dizziness or psychiatric cause. Next is the triggers. What makes the giddiness worse? For example, in BPPB, we get a classic history that lying on a particular position or rotating the head to a particular position will lead to vertigo. Standing from sitting posture, for example, in postural hypotension. Rapid head movements aggravates vertigo, for example, in BPBV, vestibular seizure or vestibular neuronitis. uh, Walking in a dark room where the if they are visually dependent and you take away the visual part, in bilateral vestibulopathy they experience severe vertigo. If the sound or light that trigger the vertigo, then it can be migrainous vertigo. If the vertigo is precipitated by loud noise or pressure changes or straining such as coughing, sneezing, blowing nose, then it can be because of the labyrinthine fistula or superior semicircular canal dehiscence. If the stress precipitates vertigo, it can be usually migrainous. And if they see moving things, then it can be vestibular seizures. Thus, it is important that we find what is the trigger for the vertigo. Now, let's go to the associated symptoms. It's important to ask for the associated symptoms of vertigo. If there is associated oral fullness, it can be Meniere's disease or labyrinthine fistula. If there is otalgia, then it can be because of otitis media or labyrinthitis. If there is facial weakness, it can be vertigo because of the herpes zoster or acoustic neuroma. If there is associated headache, then we need to rule out migraine or some intracranial space occupying lesions. If there is an associated hearing loss, it can be because of perilymphatic fistula or Meniere's disease or otosclerosis or chronic otitis media. If there is associated photophobia, it can be because of migraine. It can be, if there is associated tinnitus, then it can be Meniere's disease. If there are dangerous Ds such as dysarthria, diplopia, dysphagia, then it can be because of central cause or stroke. If there is autonomic symptoms such as nausea, vomiting, then it is more likely to be of peripheral cause, that is autologic cause rather than the central cause. We should also take relevant medical history, and it's important to arrive to a diagnosis. If there is a recent history of URTI, it can be because of vestibular neuronitis. If there is a preceding history of trauma, it can be BPPV. If there is a direct trauma to the ear, it can lead to perilabyrinthine fistula. If there are risk factors such as diabetes, hypertension, smoking, then it can be stroke. If there is associated anxiety, depression, then it can be chronic perceptual dizziness. If there is history of ototoxic use, it can be bilateral vestibulopathy. If there is history of migraine or family history of migraine, it can be migrainous vertigo. You should also ask for the history of medication they are taking. It is, there is a common saying that cardiologists give vertigo. So, still the cardiac medication, they are notorious for causing vertigo. You should also ask for ear symptoms such as tinnitus, hyperacusis, there is fullness in the ear, hearing loss, ear pain, which will guide us towards a particular diagnosis. We should also differentiate whether it's a peripheral vertigo or it's a vertigo is of the central cause. So for that, if there is associated imbalance, then it is usually of the central cause. In peripheral otologic cause, it is imbalances can be either episodic or in mild in nature. If there are neurological symptoms, the dangerous Ds, dysarthrias, dysphagia, dysphonia, they point towards the central cause. The otological symptoms such as otalgia, tinnitus, hearing loss are more frequent for the peripheral cause. The autonomic symptom, nausea, vomiting, are more severe in nature in peripheral cause, and in central cause they are variable and sometimes they may be absent. Recovery occurs usually, in peripheral cause it is rapid, but in central cause the recovery is very slow by compensation. Nystagmus is characteristic to differentiate central from the peripheral cause of vertigo. In peripheral, it is unidirectional and conjugate nystagmus, whereas in central cause, it is direction changing disconjugate type of nystagmus. The nystagmus can be positional with latency and fatigability in terms of peripheral, and the nystagmus has no latency and no fatigability in central cause. The vertigo, associated vertigo, is usually chronic and mild in nature in central cause and severe in peripheral. And any movements usually exacerbates peripheral vertigo and not so much in central vertigo. So that's how you take the history, a detailed history in case of vertigo. Now we go to the examination. Examination consists of, as the patient enters your room, you have to start observing the patient. You have to check their blood pressure and supine and lying posture to rule out any postural hypotension. Conduct detailed ear examination to see if there is any ear pathology that is leading to the vertigo. You have to examine the cranial nerves to rule out any stroke. You have to examine for nystagmus, which may be spontaneous nystagmus or primary nystagmus, and as well as the gauge-evoked nystagmus. You have to also look for smooth pursuit, saccades, and then you go to Hin's test. Hin's test consists of the head impulse test, the test of nystagmus, and the test of skew or cover-uncover test. Then you can also further do Hitzek test, cerebellar test, Rombach test, Unterberger test, Diels-Halbach test, which will lead towards some diagnosis. Now let's discuss about the smooth pursuit. The examiner holds the finger in front of the patient and he moves the finger up and down and from side to side, left and right, no greater than 30 degrees from the midline. Normally, our eye should be able to track the finger and there should be no saccadic movements. If there are saccadic eye movements, when you are doing smooth pursuit, it suggests cerebral or brainstem diseases. Saccades. We give 2 different points, and ask the patient to look at point A and point B rapidly. Normally, patients should be able to focus the eye on one point and to the next point when they should be able to jump easily. In myasthenia gravis, you observe some small amplitudes of saccades. Saccades are very slow in brainstem or cortical diseases, or they may undershoot in progressive supranuclear palsy. If the saccades are inaccurate, like instead of from A when they jump to B, they go to point C, then it's cerebellar cause. And sometimes there can be disconjugate eye movements in multiple sclerosis. So next we go to the hints examination. Hints examination consists of head impulse test, the nystagmus, test of skew or cover uncover test, and sometimes we say hints plus if you add hearing to it. So nystagmus can be normally when the patient is straight, there should be no nystagmus, that is normal. If you get horizontal unidirectional nystagmus, it is reassuring, meaning say the cause is peripheral. If there is vertical or bidirectional disconjugate type of nystagmus, then it suggests central pathology and it is worrying. So by spontaneous nystagmus, it is in the neutral gaze or primary gaze. So if you see nystagmus in neutral position, and if it is because of the vestibular cause or otolithic cause, it will be horizontal, and it intensifies if we look in the direction of the fast phase. As per Alexander's law, there are three degrees of nystagmus. If the nystagmus occurs in the fast phase, it's called grade 1. If you see straight, still there is nystagmus, it's grade 2. And if you look towards the direction of slow phase and there is nystagmus, then it's grade 3. This nystagmus can be reduced by, can be enhanced by, I mean, it can be enhanced by reduction of fixation, for example, by using Fresnel glasses. If the spontaneous nystagmus is because of the central cause, it will be direction changing, disconjugate, vertical. You should also check for gaze evoked nystagmus, that is, nystagmus when you look to the left or to the right, up or down. If it is the nystagmus is because of the vestibular cause, it intensifies on the direction of the fast phase. If the nystagmus is because of the central cause, there will be refixation saccades. So we have covered from the hints, we have done the nystagmus. Now we'll go to the head impulse test. Head impulse test detects the unilateral hypofunction of the peripheral vestibular system caused by acute vestibulopathy. Normally, a functional vestibular system will identify any movement of the head position and rapidly correct eye movement according to the center of the vision remains on the target. If there is a vestibular hypofunction, when the head is rotated towards, for example, if there is a right-sided vestibular hypofunction and you turn the head towards right, the eyes will move with it, breaking the visual fixation, and a refixation saccade is seen as the eye dart back to the examiner face. Meaning, normally the patient should be able to fix the eye on an object when you rotate the head to another direction. But if there is a vestibulopathy, they are not able to fix and there will be a corrective saccades. So how to perform the head impulse test? Ask the patient to look at the examiner's notes, and then you have to rapidly thrust the head. Either you take off the midline by 30 degree or bring to the midline by 30 degree. Normally, they should be able to fix on the target. If there are refixation saccades, then it suggests peripheral vestibulopathy. Test of skew or cover uncover test. We cover one eye for several seconds and then uncover the eye quickly. If there is realignment of the eye in vertical direction, then it is suggests central cause, and it is worrying. So you cover the eye and then uncover. If there is vertical alignment or movement of the eye in a vertical direction, that is corrective saccades in vertical direction, then it suggests central pathology. Thus, in his examination, if there is unidirectional nystagmus, there is no vertical skew deviation, there is abnormal head impulse test, then it suggests vestibular neuritis. All the four should be present. If there are any of the following, if there is, for example, a bidirectional nystagmus, or if there is a vertical skew deviation, or if there is a normal head impulse test, then it points towards central pathology, and you have to rule out stroke, and probably MRI may be suggested. So apart from the Hinz test, there are some other tests, for example, head sec test. So you shake the head from left to right, and then ask them to see straight. Then you will observe for, if there is a horizontal nystagmus, then you observe a nystagmus with the fast component away from the site of lesion. You can also do dynamic visual acuity tests to rule out vestibular disorder. Rombach test was initially designed to test for the posterior column, and they are not very specific. So you can do either sharpened Rombach test or Rombach test. Basically, you are taking away the inputs, the proprioceptive inputs, or the input from the eye, and basically challenging the vestibular system in order to compensate. If you already have a weak vestibular system, when the proprioception and the eye is removed, the visual input is removed, you will definitely have difficulty in balancing. You can also do cerebellar function test in order to rule out any cerebellar lesion. There is a Unterberger-Fukuda test. Basically, you close your eyes, outstretch the arm, and then step, and then you see how much you deviate from the position. If there is a weakness in one side of vestibular, left vestibular, for example, you rotate towards the left, and if you have right vestibular weakness, you rotate towards the right. If there are any neurological signs, there is a new type of headache or associated headache, it is worsening over the period of time, vertical nystagmus points to a central pathology, and you have to have an MRI or a neurological referral. And in Hinz case, if there is any of these, for example, either a bidirectional nystagmus or a vertical skew test, or there is a normal head impulse test in a patient with a vertigo with nystagmus, then you have to worry about the central cause and rule out stroke. So this is about the history taking and physical examination in a patients of vertigo. So most of the diagnosis, around 90% of diagnosis can be achieved by proper history and examination alone, and therefore we need to take a thorough history and then conduct a thorough examination to arrive at a diagnosis.